So now it's time to introduce our speakers. Actually, Dr. Shermer will be going first, but I'd like to first introduce Dr. Amelia Chase Weiss. Amelia is a pediatric integrated behavioral health provider at Norton Children's Medical Group in Frankfort and in Shelbyville. She completed her PsyD in clinical psychology at Eastern Kentucky University and is completing her postdoctoral fellowship. In her practice, she frequently uses her training in parent-focused interventions to help children with anxiety or challenging behaviors. Her training in the collaborative assessment and management of suicidality informs her work with teens and children who are struggling with suicidality. Seeing clients develop a sense of hope is her favorite thing about the work that she does. Our first speaker today will be my colleague and friend, Dr. Mark Shermer, who serves as the Director of Psychological Services for Norton Behavioral Medicine, delivering mental and behavioral health services virtually in conjunction with the Norton Healthcare network of primary care clinics. In addition to providing direct clinical care, Dr. Shermer conducts oversight and training for the Norton Behavioral Medicine team of therapists. Mark has a secondary role as the provider of our provider wellness program, which is a professional coaching program to address emotional and behavioral health needs of physicians, advanced practice providers within the Norton Healthcare system. So welcome, Mark and Amelia. And Mark, I'll let you start us off this morning. Dr. Shermer.
Good morning. I can finally start my video. Okay, great. Hi, everybody. I'm happy to have the opportunity to talk with you today. I know this is an important topic that a lot of folks express discomfort with, and I myself have been through that as well as a clinician. Let me kind of jump into this. So just start out, I want to note that we don't have any disclosures to make here. We have no conflicts of interest here. And also neither one of us has any kind of financial stake in any of the materials we're presenting, any of the sources, sites, or authors in our presentation. So we're just here to try and help everyone get more comfortable and more knowledgeable about these things, and also just sort of reinforce our own knowledge base, because we have to apply this on a regular basis in our clinical practice. Okay, so we did this, disclosures, here we go, objectives. All right, so first of all, we're going to look at the prevalence of suicide and suicidality, and that's going to include some talk of terminology. What kind of language do we use around suicide? And what do we mean by different terms like suicidal ideation, intensity, suicidal behavior, things like that. We'll look at risk factors that are associated with suicide. Some of these are demographic, some of these are occupational. We'll look at protective factors like self-care and resiliency, and how these can aid in suicide prevention or help protect against risk for suicide. Then later in the presentation, we'll be looking at systems of care, evidence-informed approaches, and then best practices to help reduce suicide rates and reduce the risk for suicidal intensity. We'll look at the ethical and legal considerations when it comes to caring for patients who are suicidal, things like mandatory reporting, duty to warn, and not only working with patients, but also some ethical considerations when it comes to dealing with colleagues who may or may not be suicidal. And then we're going to look at toxic stress and secondary trauma and how these experiences can increase a person's risk for suicide. So let's start a little bit with some terminology. Suicidal ideation is something that comes up a lot. Even those of you who are clinicians, you'll see documentation where it notes the presence of SI or a patient denied SI. And this can kind of mean different things to different people. For some folks, SI means someone is thinking about suicide. In other cases, it could be that someone is really feeling some internal pressure to act on a suicidal impulse. So in a general sense, thoughts about death, dying, or not being alive are fairly common. Our brains are wired to solve problems, and sometimes if a person's in a situation where they can't think of a solution, their brain might say, well, if we weren't alive anymore, we wouldn't have to deal with this, or if we could go to sleep and not wake up. So if you're encountering someone, whether it's a colleague or a patient, who is reporting these types of thoughts, just respond to it empathically. Don't panic. Just because someone is having these thoughts doesn't mean that they're feeling pressure to act on it. And I just want to take note of the fact that we have almost 500 people in this meeting right now. And technically speaking, we're all thinking about suicide right now. It doesn't mean that we're feeling pressure to act on that. It's just something that we're thinking about, which is different from suicidal intensity. This is what occurs when stress overwhelms a person's ability to cope. They can't come up with any more solutions. They don't know what else to do. And so suicide is looked at as a possible solution. It's a way out. It's a source of relief, where death is seen as the end of pain. So there's not just a thought about dying, but there's a desire to die with possible intent to act on that, and maybe planning going into that, making some sort of preparation, which is a form of suicidal behavior. Suicidal behavior is any sort of act that is related to preparing for or attempting or carrying out suicide. So the preparatory acts could be things like getting materials together, purchasing a firearm, purchasing rope, collecting pills. In an inpatient facility or in a hospital setting, sometimes people will cheek their medications, like store their pills in their cheek rather than swallow them, so that they can stockpile them and take a number of them together at the same time. There might be some sort of rehearsal of the act, maybe holding a gun or holding a blade. And then there could be some other preparatory acts, like completing a will, giving away possessions, completing a DNR, so that if someone is found alive, that they're not resuscitated. Second category is a suicide attempt. So an attempt is any kind of non-fatal, self-injurious act that is done with the intention of dying. It's done with the expectation of dying. It's important to get away from a term like suicidal gestures. I've talked to some people who were trained more recently than I was, who aren't familiar with that term, but I know when I was an undergrad and even early on in grad school, sometimes there would be talk of someone engaging in suicidal gestures. In other words, behavior that seems suicidal but is not really intended to die. And the problem with that is a number of things. One, it assumes that the person's motives are known, that they don't really want to die. It's also assumed that the behavior won't be fatal, when in fact some of the things that are in the past have been referred to as suicidal gestures have resulted in death, such as cutting. So want to get away from that term. So there could be aborted attempts. That's where an individual will stop themselves before completing attempts. So they started, but then they stop themselves in some way. Or there's an interrupted attempt where there's some outside circumstance that disrupts the person's attempt. So an attempt is not completed. Completed suicide is really when death results. We want to get away from terms like a committed suicide. That term, and I'll be transparent, every now and then I catch myself saying it or starting to say it, because that's just what I heard for decades. The problem is that that term is rooted in a time when suicide was considered a crime. So if someone has died by suicide and we're saying they committed it, not only has someone died tragically, but now we're identifying them as engaging in a criminal act. And so we need not add insult to injury. Likewise, calling it a successful suicide is fairly insensitive to the survivors of the person who has died, or people who have been touched by suicide. Suicide is not a success. It's something that someone has completed or someone has died by. There are different general factors that can motivate suicidal behavior. The first are respondent factors. In other words, these are the behavior is a response to something that's going on. So the suicidal behavior is a result of some sort of situation that the person finds themselves in, or some sort of stimulus. It could be an external stimulus, it could be an internal stimulus, like a thought or an emotion. So some examples would be that suicide is an escape behavior. Someone is in a lot of emotional pain, or they're in an untenable situation, and suicide is an escape. So, or perceived as an escape. So in this case, they're responding to something, versus an operant factor. These are factors where the suicidal behavior is intended to achieve some other secondary outcome. So it could be that it's a way to control the person's environment. It could be that it's a way to affect something in a relationship with another person. There have been cases I know from my past working at the VA that people will engage in suicidal behavior so that they can be hospitalized, which can be a way to access warmth or food. And in some cases, people will engage in suicidal behavior to make some sort of political statement. We certainly saw that during the Vietnam War. So as I noted before, suicide attempts are behavior that's really motivated with the intention to die. People believe that their actions will likely result in death. Important to note that a majority of people who attempt suicide are female, and a majority who complete suicide are male. And that really comes down to the lethality of the means and what's known as the reversibility. And so when someone engages in a suicidal behavior, once that behavior is complete, how long is it possible for the consequences of that behavior to be reversed? So in the example of overdose, it's possible to potentially call the paramedics, have someone's stomach pumped. Other drugs can be administered to help prevent the person from dying, whereas with a gunshot wound, in many cases, death is instantaneous. So that reversibility of the means is one of the key factors in whether attempted suicide crosses over into a completed suicide. So there are three types of attempters. There are people who are interrupted and rescued by others. There are people who panic after making the effort and then seek help during that window of reversibility. And then there are people who misjudge the lethality of their means. And it's important to understand that if someone makes a suicide attempt, if they believe it's going to be fatal, even if from the outside looking in, you can recognize that, for example, taking a whole bottle of Flintstone chewable vitamins isn't going to be fatal. It's important to take that seriously because the person might just learn from that. And research has shown that 10 to 15% of people who attempt suicide will eventually complete it. And 25 to 30% of people who make one attempt will actually make multiple attempts. So in some cases, if someone makes an attempt with non-lethal means, it could be that that's a learning process or a type of rehearsal. So that needs to be taken seriously and not just treated as attention-seeking behavior. Looking at various racial and ethnic groups for past year suicidal thoughts and attempts in the United States, unfortunately, due to the methodology of the data collection, we don't have data on suicide attempts for Native Americans and Alaska Natives. Interesting to note that the rate of serious thoughts about suicide is lowest for Native Hawaiian or other Pacific Islanders, and the rate of suicide attempts is highest for that same group. White adults have the highest rates of suicidal thoughts. You can see it's not the highest rate of attempts, but just because of population sizes, a majority of people completing suicide, or people completing suicide, I should say, are most likely to be white. Worldwide, there are about 800,000 suicides completed each year. In 2020, in the United States, there were almost 46,000 suicides completed, which was down from 2018, which over 48,000 people completed suicide. But it's important to note that the decline was really accounted for by a decline among white males. It's the only demographic group that saw a decline in its suicide rate. But it's such a large portion that it affected the overall suicide rate. But other demographic groups are not seeing declines. Likewise, in 2020, there were 1.2 million suicide attempts, down from 1.4 million in 2018. And that comes out to roughly 138 suicides per 1 million people. As I noted before, men die at higher rates than women. That's about 3.6 times more likely than women to die, even though women make more attempts. And about 70% of these suicide deaths were accounted for by white males. Important to note that firearms accounted for more suicide deaths than all other methods combined. And that's true In the United States, you can see here firearms were about 53% of all suicide deaths versus the remainder. And in Kentucky, that discrepancy is even greater. Almost 2/3 of suicide deaths in Kentucky are the result of firearms. Now, the next slide is it's a heavy one, not just as a clinician, but also as a parent. Suicide is now in the top 10 leading causes of death for children ages 5 and up. And across all age groups from 5 to 64, suicide is a top 10 leading cause of death in the United States. I think this might, if I remember correctly, I think this might be the first time that suicide has made it in the top 10 for ages 5 to 9. And again, having access to a gun in the home is the #1 risk factor here. Couple points I want to make. There's a lot of information that's been in the news over the last 20 years, really in the last 40 to 50 years, about rates of suicide among veterans following the Vietnam War and following the wars in Afghanistan and Iraq. And I just want to make note that among veterans, suicide is the number 13 leading cause of death. So if you look at causes of death, as much as veteran suicide is talked about in the news, it's actually ranks lower than it does for the general population, including children. Just by comparison, for ages 65 and up nationally, it's the number 18 leading cause of death, and across all age groups, it's number 12. In Kentucky, the rankings look pretty similar, although suicide is not ranked in the top 10. It's actually not listed as a cause of death in this data for ages 5 to 9 in Kentucky or in Indiana. Some of that might be a methodological issue. But suicide is the second leading cause of death in Kentucky for ages 10 through 34. So it's the same for 10 to 14, 25 to 34, but for 15 to 24, it's number 2. Same rank for 35 to 44. It's number 8 for 45 to 54. And then it's number 11 for 55 to 64. Very similar pattern that you see in Indiana. It's very much mirrors what you see in the whole in the United States, except for ages 55 to 64. It's number 11, and it's not ranked for ages 5 to 9. The CDC collects information on suicide rates by occupational categories. And so I compile lists of the top occupational suicide rates for men and women. I bolded several of these because many, if not most of the people in this training work within the healthcare industry in some means. And so I bolded the ones that on the surface are certainly the most relevant. Protective service occupations includes first responders. We have personal care and service occupations, healthcare practitioners, and then healthcare support. And I did the top 11 because for men, healthcare support is number 11, and I didn't want to include that just by doing a top 10 list. So note that for men and women, that the occupations most closely associated with the healthcare industry are in the top 10, top 11 for highest occupational suicide rates. And I was reflecting on this morning, actually, and didn't change the slide, but within a large organization like Norton, and if anyone's here in another healthcare organization, this is going to hold true as well. There are a lot of people who work within our industry who aren't healthcare providers, who do things like take care of building maintenance or janitorial services. And note, for men, installation, maintenance, and repair occupations, that actually is the second highest occupational suicide rate. And building and grounds cleaning and maintenance occupations is number 7. And so with all of the focus that we're putting today on assessing and addressing depression and suicidality in our patients and in our colleagues, it just raises the question in my mind: how much are we checking on the other people, the people who are emptying the waste baskets or cleaning the restrooms or coming in and fixing the air conditioner? You know, like how much are we really interacting with those folks. And so just something I want to kind of plant that seed to be thinking about, not just healthcare providers, but really all the people who are part of the organization who help us achieve our mission. Looking at what characteristics are we most likely to see in a person who completes suicide? In most cases, the person is white and male, an adult, 25 years or older. Age 65 and up, the risk is even higher. And part of that might have to do with the fact that being alone, living alone, whether it's through separation or widowhood or being divorced, increases the likelihood of someone attempting and completing suicide. Living alone, a lack of social cohesion. You know, as a therapist, I work with a lot of folks who struggle with anxiety. And one of the things that happens when people are socially isolated, whether they're anxious or depressed, is if they're not interacting with other people, then their own thoughts kind of become this echo chamber. And it's really very easy to get caught up in rumination. So by being alone, if someone is having discouraging thoughts, they don't have another point of view to kind of help be a source of hope. Likewise, as people, we're wired to be social. And so if we're not connecting to other people, that's going to increase the likelihood of hopelessness or despondency. So along those lines, being unemployed or retired also is going to decrease the likelihood that a person is going to be in contact with others, and it can be associated with a loss of meaning. People a lot of times find their work to be very meaningful, and when that goes away, now what? Poor physical health is commonly seen in people who complete suicide. So a sense that maybe things aren't going to get better. Chronic illness, for example, can be seen. Most often people will leave suicide notes, but it's important to note that doesn't always happen. And so sometimes it's uncertain whether a death is a suicide. There's some research that shows that in some cases, single vehicle motor vehicle accidents might actually be suicides that are done to look like accidents so that family members can still collect health insurance or life insurance. So when you look at like the causes of death, some of the accidental death statistics might actually include suicides that weren't identified as such. People who complete suicide often have some sort of mental health problems, whether it's been diagnosed or not, whether it's been treated or not. So it could be mood disorders, anxiety disorders, some sort of thought disorders, or substance use disorders. And most often, providers have seen these patients within 6 months of suicide. So important to note that people are seeking some help, and it's going to, we have a responsibility to do what we can to catch them. So it's not that people have fallen off the grid. In many cases, they've recently seen their primary care provider before attempting and completing suicide. Other characteristics often seen in people who have died by suicide is having a history of attempts with highly lethal means with a small window of reversibility, like using firearms, hanging, or jumping, or in situations in which the person survived the attempt because of the intervention of someone else. The last one is also one that as a clinician I find stressful to think about, which is that the person who's completed suicide is most likely not reported their intentions to others. One conversation I had with a patient one time was, if I told you that I was thinking about suicide, or if I told you I was going to do it, you would just stop me. So I would never tell you. And while I appreciated the candor, I remember just having this sort of a cold chill come over me. But it's something that we have to really learn to tolerate as clinicians, is the uncertainty, even though we've got to do our best to gather the information that we can. So there are some red flags to be looking for then, if we're going to catch them. Significant psychological turmoil. What's going on with the person emotionally? What's going on with them mentally? What's happening with their thoughts? And almost, if not more important than that, what's the person's relationship to their thoughts and their emotions? Are they fighting against their thoughts? Or are they fighting against their emotions? Because that tends to actually increase turmoil in many cases rather than resolve it. Has there been a change in their eating habits or sleeping habits, especially a recent change? And that could be eating more, eating less, sleeping more, sleeping less. Are they more irritable or aggressive than usual? Are they having trouble with concentration? Can they focus on things? Focus on work, focus on recreational activities, focus on relationships, focus on a conversation? If they do have any kind of psychiatric symptoms, have those symptoms gotten worse recently? Do they express a sense of despair, this kind of fatalistic hopelessness that things are never going to get better? Are they engaging in risky behaviors? All of a sudden, are they going skydiving all the time, even though that's nothing that interests them? Are they doing things that are riskier? Increasing substance use, it can be another risk-taking behavior. Do you hear them putting themselves down a lot? One of the things I listen for a lot is people who just apologize all the time. They feel like they're a burden to others. They feel like they're doing something wrong. And that can be a red flag for that self-evaluation. Can they enjoy themselves? Do they derive pleasure from anything? Or are they giving things away? Does it look like they're sort of preparing to say goodbye? One other risk factor that can be challenging to identify and manage is what's known as the amazing reversal. With this, someone has been struggling for a long time. They've been having a lot of difficulty with their physical health or their mental health, and all of a sudden everything gets great. And they're fine, they're cheerful, they seem hopeful, they're not upset anymore. It just seems to almost come out of nowhere. And it can be very reassuring for family members. And as a clinician, it can certainly, it's always nice when your patients seem like they're getting better. The problem with this amazing reversal is that the reason the person seems to be feeling better is because they've made up their mind that they're going to die by suicide. And the thought of suicide, the fact that they've made a plan to do it, has given them a sense of peace that this is all going to be over soon. And so that can be really challenging. It can bring up feelings of guilt. If you're working with someone who's a survivor of a loved one who's died by suicide, in many cases, people feel really guilty that they didn't see the warning signs. Everything seems so much better, and then all of a sudden, this happened. And why didn't I catch it? But that's something to be looking out for. And then lastly, if someone's taking care of legal matters, if they're completing the will that they've been putting off, or suddenly you're getting a DNR, which again, in our field, those are very common things. It's important to take care of yourself legally in those regards, but that can also be a red flag. So moving from like a potential red flag to something a little more intense, serious risk. If someone's talking about feeling trapped or in unbearable pain or being a burden to others, if I weren't around, my family wouldn't have to deal with this anymore. Other people would be happier if they didn't have to listen to me. There's increased use of substances, or if someone is really getting a lot more anxious or agitated, they're more reckless, they're sleeping way too little, hardly any sleep at all, or sleeping way too much, they're hardly getting out of bed. They express a strong sense of being isolated, or if they're isolating themselves, if they're pulling back from other people, or showing intense rage, or talking about revenge, or really showing any kind of really extreme mood swings. These can all be signs of serious risk, but especially if it's a new behavior, or if it's increased over the way it's been in the past, or just seems like it's been triggered by a painful event. You can say, oh, this happened, and now it set off this other pattern of behavior that could really reflect serious risk. Moving a little farther along the spectrum to immediate risk. If someone is saying that they want to die, or they want to kill themselves, or they're planning on doing it, they're looking for a way, like searching online for methods or materials, or they're obtaining a gun. If they're saying, I'm hopeless and I have no reason to live, these are all signs of immediate risk. If they're trapped, they have no way out, or they perceive that there's no way out, and they're actively engaged in planning, take that as immediate risk. This is not the time to try and figure out if it's attention-seeking behavior. It needs to be treated as immediate risk. There are some just sort of general risk factors to consider. As I mentioned before, a significant portion of people who would attempt suicide will make more than one attempt, and a significant portion of people who make attempts ultimately will complete suicide. In general, any sort of misuse or abuse of alcohol or other drugs carries a risk factor. One of the conversations I've had with patients before is, how does it affect you if you're using a drug that is a depressant? How do you not be depressed if you're using it and misusing a depressant? Or having access to lethal means, like having a gun in the home. There's some research that shows like the number one thing to do to reduce the risk of death by suicide is to get firearms out of the house. Knowing someone who's died by suicide, especially a family member, is also a general risk factor. Having a loved one die by suicide, or a parent. And you think about, we learn from our parents or the people who raised us. We learn from our caregivers how to manage our emotions and how to cope. And if a parent or caregiver has died by suicide, part of the message that sends to the people they were raising was, this is a way out, or if things get bad, this is a strong option. So that's part of where that risk factor comes in. It's not just the grief from the loss of the person to suicide. It's also that in essence, people will infer from that's a way out. Or maybe the parent who died by suicide or the caregiver who died by suicide just didn't have the coping skills to teach that person, and so they never got to learn them in the first place, which is part of why they come to therapy. Social isolation. This can go a couple ways, whether it's someone who's actively isolating, or it's someone who is isolated, say perhaps from prejudice and discrimination. If they're living in an area where they don't have a lot of social support for the communities that they identify with, if they're isolated by other people, like for children and adolescents, bullying is a big source of social isolation. These carry big risks. As I alluded to before, chronic disease and illness or disability can help foster this narrative that things are never going to get better. It's always going to be like this. There's no hope. And that sort of gets that brain looking for, well, what could I do so I don't have to feel this way anymore? If there's a lack of access to behavioral health care, in Louisville, it's not as much of a problem as it might be in some of the outlying rural areas. One of the great aspects of telemedicine is it's easier to reach people farther away. The downside is some people don't have access to technology or are not adept at using it. Likewise, some levels of healthcare require a certain level of specialization or require more than just outpatient care. And that care might not be available in a person's area. So for example, there's not a residential treatment program in the state for someone, say, who has a severe eating disorder. So we have a patient who has very severe eating disorder. We have to send them out of state. There's not a residential program for a number of mental health diagnoses. And so not everyone can travel to Wisconsin, for example, and go to a residential facility for 4 months to get the care they need. So if they can't access it, they're going to be more likely to contemplate suicide. And then lastly, I already talked about prejudice and discrimination. We'll come back to that in a couple more slides. But then psychiatric disorders, I'm going to expand on that right now. So depression is implicated in about 40 to 60% of completed suicides in adults, but it's not necessarily the same diagnosis. So in men, suicide is more likely associated with major depressive disorder. In women, it's more likely associated with postpartum depression. Bipolar disorders have a higher risk, especially for bipolar 2. Some of the thought there is with bipolar 2, where a person experiences hypomania instead of mania. The hypomania, it can be activating, but it also doesn't have that same euphoria that can come with mania. Some people who have bipolar disorder really like the mania. They enjoy that, which is why some folks are reluctant to take medication for that, because they kind of get a high from that. And if you're feeling high and euphoric, you're not going to be thinking about suicide. And the flip side is when they're in the really deep depths of depression, in many cases, they don't feel like they have the energy to act on suicidal thoughts. Although people who have bipolar 1, that's rapid cycling, where there's a rapid switch between the depression and the mania, have an increased risk, because then when they're depressed, sometimes they get the level of energy to act on the thoughts that they're having. With borderline personality disorder, about 8 to 10% of people with BPD die by suicide. Borderline personality disorder is also associated with non-suicidal self-injurious behavior, such as cutting. And in some cases, because of that, the suicidal behavior is, in the past, and this is anecdotally, but sometimes it's not taken as seriously because it's perceived as a ploy for attention. But it's important to note that sometimes that behavior that's not intended to be suicidal can result in death. And likewise, someone who is engaging in any kind of suicidal behavior, it just needs to be treated as a safety issue rather than trying to figure out, do they really mean it? But the risk for death by suicide is extremely high for BPD. Likewise, with PTSD, if you look at how PTSD is diagnosed and what the symptom clusters are, one of them is a persistently negative emotional state. Another is a difficulty or inability to experience pleasant emotions. So not only are things like fear and anxiety and guilt and shame and anger predominant emotions, but there's a difficulty accessing hope and joy and love. So it's almost like a perfect storm for suicidality. Generalized anxiety disorder carries an increased risk, although one thing that I've just observed anecdotally is generalized anxiety disorder is often overdiagnosed. So in many cases, providers will see someone who seems anxious and they're diagnosing generalized anxiety disorder, which GAD really means you're anxious about pretty much anything and everything, a wide variety of things. It's not the same as like an unspecified anxiety disorder. So just want to make that note. Schizophrenia, 20% of people who have schizophrenia will attempt suicide at least once. About 5 to 6% will die by suicide. But it's important to note it's most likely to occur when the person is depressed than when they're really actively psychotic, although command hallucinations where they're hearing a voice telling them to hurt themselves can carry an increased risk. And then lastly, people with obsessive compulsive disorder have a risk for suicide that's about 10% higher than the general population. There are some general psychological vulnerabilities that can increase the risk, like neurotic perfectionism. In other words, this idea that I have to be perfect or else. Perfectionism is a way to try to escape a sense of failure or escape criticism, or maybe someone was raised with a demanding or abusive parent, and perfectionism was a way to escape punishment. So people have an intense need to avoid failure. Nothing ever seems to be good enough. And so it makes it really hard to get satisfaction from really doing anything. Or there could be performance anxiety. Some people were raised in an environment where love seems to be conditional. So they have to really do a great job of everything, or else love is inaccessible. And so a high performance is seen as the path to love. And if you can't perform highly, then you can't be loved, and maybe you're not lovable. If someone has an external locus of control, things seem like what's going on around them is out of their control and they can't solve their problems. It feeds into that hopelessness and helplessness and just sort of a sense of being defenseless against life in the world. Emotional constriction is important to note that because that can come as a consequence of a disorder, or it could be something that someone actively pursues to escape a symptom. And what I mean by that is in many cases, people will actively do things to try to avoid what makes them feel anxious or sad or angry or embarrassed. And the problem is when you try to avoid an emotion, the only way to do that, like the only way to avoid anxiety, is to avoid all of your emotions. So if you're avoiding anxiety, you're also going to suppress your confidence. If you're trying to avoid your sense of shame, you're going to also suppress your sense of hope and love. And so just by trying to distance yourself from an uncomfortable emotion, what happens is it kind of cuts you off from the pleasant emotions too that can help protect against suicidality. It's important to note that the risk for suicide increases with the number of major life stressors. There are some biological differences within the brain. We're not going to be taking a dive into those today, but I did want to note that there are some biological differences that can mitigate that. But generally speaking, you can see almost like a dose response. The more major life stressors a person has, the more likely they are going to have to contemplate suicide. We mentioned substance use disorders on a couple of slides, but let's look into this a little more closely about specific risk factors associated with that. So a lot of times people are using substances to try to numb out an emotion or avoid a problem. And if you're disconnecting from your emotions or from life in general, it's really easy to lose your sense of confidence, you lose your sense of hope. And you know, if you see that even more if the substance use was started during adolescence. Now people have started it before they've really learned adult, mature ways of coping with life stress, or if it started early on as a way to self-medicate. A lot of times there are a lot of consequences as a result of substance use. And the more those consequences build up, whether it's losses of relationships, involvement in the criminal justice system, or becoming addicted to more and more substances, the more those things pile up, the greater the risk for suicidality. A lot of folks who use substances have low self-esteem. Sometimes that might motivate the substance use. Also, it's an identity that carries a lot of social stigma. And you know, not feeling like they're in control of themselves, in control of their emotions. If they were really down on themselves, and then on top of that, they start having a kind of an accumulation of health consequences, all of this can drive that. On the personality side of things, if someone has sociopathy, someone, in other words, who doesn't really connect emotionally with other people, and is just sort of doing their own thing. This is what we see associated with like psychopaths. That type of individual is more likely to be at risk for suicidality. And then if someone's had a lot of treatment failures repeatedly, think of how all these things connect. It's not just, oh, someone's had a lot of treatment failures, but think of what that could do for hopelessness and helplessness. And some of that might be rooted in having a family history of substance misuse. Again, if the parents are doing it, what skills are they going to teach their children how to manage life? And along those lines, if they've been a victim of child abuse, people will look for more escapes to the pain that they experience. And that can also be a driver for engaging in substance use at an earlier age. Now, in terms of, let's see, now I just want to take a pause for a moment. I know some questions are coming in on the Q&A. There's some moderating going on. I don't know if a moderator is going to be posing those to me or if you want me to check these.
We will address them at the end.
Yeah,
Okay.
we'll do them at the end, Mark.
Okay. All right. When I see the little red number popping up, I'm like, uh-oh, I just want to make sure nothing's getting missed here. All right. So let me go back. So by age groups, you know, earlier we were looking at suicide rates among different age groups. In a more general sense, let's look at these in larger groups. So across adults, loss is associated with the greater risk for suicide. So it could be a loss of relationships, a loss of health, a loss of social definition. And there's some research that shows that a sense of being alone in the world might be more painful than just the loss of a single primary relationship. So it's as painful as it is to lose somebody. If you just have a sense of not being connected to anyone, that might be even more painful for people. Or a loss of occupational definition. You know, if you remember earlier, I said people over the age of 65 have a much higher risk of dying by suicide, and some of that might be that if you define yourself by what you do, like if I am a psychologist and then eventually I retire and I'm not a psychologist anymore, well then who am I? So there's that existential crisis that can come with retirement or getting terminated from a job, whether it's a layoff or firing. And so this could be one of the factors that contributes to the higher suicide rate among older white males. Likewise, we talked before about the history of suicide attempts, and then knowing someone who's died by suicide, particularly a family member. With regard to adolescence, If someone is self-medicating for some sort of untreated mental illness, again, something's not working. A person needs help, they're not getting the help, and you're looking for solutions. That sense of aloneness or isolation. So if you're working with an adolescent, ask them, tell me about your friends. Same, really true for anybody. Tell me about your friends. What's your social support look like? Being a target of bullying, being from another country, how much people have, if they are, whatever their immigration history is, how much have they acculturated to where they're living. Sexual orientation and gender identity are pretty huge factors. I have a slide on that coming up in just a few minutes. Any sort of academic performance anxiety, again, that neurotic perfectionism is a factor. Being believed that love is earned through performance is huge. And if they can't manage failure, one of the things with adolescents is their brains are still developing. And so there's a lot of this all or nothing thinking that if you're not first, you're last, or if you haven't succeeded perfectly, then you failed. Any kind of family discord or impulsivity, and again, access to firearms and loss of a loved one are really huge risk factors for adolescents. I'm so sad that I have to have a slide on this, but it's true. Children, like we noted before, suicide is a top 10 leading cause of death. And in many cases, it's the loss of a significant loved one. Some cases with young children, they might not understand that death is irreversible. And so if they have this idea that, well, if mom is in heaven, I could go to heaven and I could see mom, and then I'll come back tomorrow and go to school and see my friends. It'll be great. And so kids who don't understand that death is irreversible might engage in a suicide attempt just to try to reconnect with the lost loved one. Also, children don't have a great sense of time. So you think about if you're 5 years old, something that lasts 1 year is 20% of your life, and so they don't have that time perspective. The part of the brain that perceives time hasn't fully developed. And so an unhappy situation might be seen as eternal. And so like bullying might be seen as something that's never going to get better. So again, children and adolescents, bullying, if you have any takeaways, just what's going on at home, what's going on at school, and do they have access to means are huge. If you look at the lifetime rate of seriously contemplating suicide among the general population of the United States, it's about 16% of all people will seriously contemplate suicide at some point in their lives. If you look at sexually diverse and gender expansive populations, however, that risk increases by a factor of 2 to 4. So it's 2 to 4 times higher than it is for straight cisgender adults. So among the general population, it's 16%. Among lesbians, it's 35%, 37% of gay men, 39% of bisexual men, 40% of bisexual women, and then 71% of people who are transgender or gender expansive report by adulthood. And again, this is people who are still alive report this, report that they have seriously contemplated suicide at some point in their lives. This does not capture people who have completed. A study found in 2018 that nearly 1/4 of lesbian, gay, and bisexual high school students had attempted suicide. Again, this does not capture completed suicides, but 1/4 had attempted suicide over the previous 12 months versus 6.4% of their straight peers. So in other words, 4 times as many, roughly, attempted suicide over the previous year. And there's also research that shows that sexually diverse individuals who live in communities that have really high levels of structural stigma have a life expectancy that's about 12 years shorter than people who reside in low stigma areas. And one of the factors driving that higher mortality is the risk for suicide. There are certainly protective factors like having social support, having children at home, especially if there's a sense of responsibility to the family, any kind of sense of meaning or purpose in a person's life, a sense of satisfaction is going to be protective. Having some good ways, strategies for solving problems, practical problems or emotional challenges is important. Some spirituality or religious commitment, not necessarily belonging to a church, but certainly that is going to be protective if someone has a sense of belonging to a community. If someone's really actively participating in their treatment and has a good relationship with their providers, those are all things that can be very helpful. Also, having a good reality testing ability. In other words, can they tell if what's happening is real or if it's maybe something delusional or hallucinatory? Having a plan for the future. That's one of the great things about making an appointment with the patient is they have something on their calendar, something that they can look forward to. If there's a restricted access to means or fear of death or fear of social disapproval, some people don't want to make it even an attempt because of how that might look to others. And before I turn things over to Dr. Chase Wise, I just want to make a note about suicidal obsessions. This is something that I treat in my work at times. It's important to determine whether, when someone is having suicidal ideation, whether it reflects suicidal intensity or suicidal obsessions, or both. Suicidal obsessions, in other words, these are recurring, intrusive, unwanted, unpleasant, in many cases frightening thoughts about suicide, might actually be symptomatic of obsessive compulsive disorder rather than suicidality. So the thoughts of suicide are arousing fear and anxiety rather than comfort and peace. And people worry that they might attempt it, not that they want to, they're worried they might not do. And you might even hear them say, I would never do that, I would never want to, but I keep thinking about it. So they might seek reassurance from loved ones. They might seek reassurance from medical providers. Many of these people will be in the emergency department a lot, reporting that they're having thoughts of suicide that they find terrifying. And so it's important to ask, how do you feel when you have thoughts of suicide? And if they have a sense of peace and relief, that might reflect more suicidal intensity. Whereas if it's anxiety and fear, it could be suicidal obsessions. So even though OCD is highly comorbid with depression and the risk for suicide is higher, in some cases, people who have OCD are worried that they're going to attempt suicide, and providing reassurance that they're not going to can actually heighten that. So it's important to get those people assessed for OCD if you are seeing that. So with that, I want to turn things over to Dr. Chase Wise.
Hi, everybody.
Did we want to take one or two specific questions for Mark, or wanted to wait till the end?
I'd be happy to answer any questions.
Because there were a number, Dr. Sherman, there were a number of questions that came in about the role of complex trauma, but Dr. Chase Wise may touch on that. But I think several were interested in the great reversal, that when an individual experiences that increased energy or they're feeling better, is there any other thoughts you have about how to navigate, or what kind of interventions, particularly in primary care, you can institute when patients are feeling better?
Yeah, well, I would say really talk to them about what they think is the reason for that. You know, if they're just like, I don't know, I just feel better, or talk to them about it. You know, sometimes people feel better because they are thinking more about suicide. I wonder if that might be something that you can relate to in some way. You know, it's like not shying away from the topic. And I've honestly, I've been doing therapy for a number of years, and people generally have an idea of why they're feeling better. So if they can't answer that question, that might be something to consider. Dr. Chase Wise, I don't know if you have another point of view on that one. But we do have slides coming up on complex trauma.
Good.
Yes. And of course, at the end, Mark and I can both kind of answer the questions that haven't been answered by our slides. But yeah, I mean, I think the same thing about just asking more questions and trying to figure out what's going on for them.
I think the concern always is that we do the screening initially, and then we forget to continue to ask about those type of risk factors. And so yes, we'll definitely touch on that at the end too. But Dr. Chase Wise, why don't you go ahead, and thank you again for being with us. All
right. So Dr. Shermer gave us lots of kind of background and stats about suicide. And I don't know about you guys, but when I hear all those risk factors, it's kind of overwhelming, right? You could probably look at all those risk factors and think of how many apply to you, how many apply to your loved ones, or to different people at different times too, right? So taking kind of all of that information, I wanted to share with you guys this theory of why people die by suicide, Joiner's theory, that essentially boils it down into three basic conditions that contribute to risk. And so we can kind of take all of these risk factors that we've already talked about and boil it down into, this kind of working model for you of how to conceptualize risk. To me, this is important when I'm assessing for risk. I'm kind of hearing these things in these categories. So the first condition that contributes to risk is the acquired ability to enact lethal self-injury. That's basically practice. Practice kind of being desensitized to self-injury. That's something that's developed over time and with repetition. And let me read this quote for you. So he says, people who have hurt themselves before, especially intentionally, but also accidentally, who know how to work a gun, who have investigated the toxic and lethal properties of an overdose drug, who've practiced tying nooses, are viewed here as at substantial risk for suicide. So you can hear those things and it's like, that's where our practice affects, our practice with, I think Mark mentioned, like holding a gun or thinking through some of this stuff. Notice though, a lot of people would have the acquired ability to enact lethal self-injury, right? Think about healthcare professions. Do you guys know about toxic and lethal properties of an overdose drug? I mean, probably it's kind of part of the job, right? Also, Mark and I kind of talked pretty extensively about this topic, and it's like, you guys working in hospitals see people who have attempted suicide. You see kind of what works, what doesn't work, right? And so there's just increased knowledge that contributes to risk, right? If you don't have that knowledge, then it's not as big of a risk factor. But not everyone who has the ability to enact lethal self-injury thinks that suicide is attractive at the time. So these two other parts kind of contribute to the attractiveness of suicide at the time. So we have afforded belongingness, feeling like you don't belong in a group. So think about those protective factors, right? A lot of those had to do with belonging to a group or feeling like you're cared about by other people. And then our third condition is perceived burdensomeness. That feeling like you're not contributing, or you're actually, people are worse off because you're there. Thoughts like that are, those two factors. So like I said before, the first condition, lots of people have that. A lot of people will find, suicide attractive, but might not have that first condition. So really, we're looking for all of these three conditions when we're assessing for risk. If I hear we've had several suicide attempts or other kind of practice with self-injury, and I also hear that they're not feeling like they belong and they're a burden to other people, then that's like very high risk in my mind. So moving on to kind of our ethical and legal considerations here. So basically we have kind of two different relationships that we're going to talk about. And a lot of my slides also have to do more with kind of peer relationships too. But before we get into that, let's talk about professional relationships and patient care. So what are our legal and ethical duties here? So we have a legal and ethical duty to keep people safe, right, when they are in our care. So principles at play are patient autonomy. Generally, that means that people are in control of themselves, right? They get to make choices about what happens to them. Well, what about suicide, right? We don't really let people make that choice. Why not? Why don't we just let people, decide when their life ends? Well, we know that suicidal ideation and suicidal thoughts, typically that is brief and time limited. And so in one moment, someone may feel like they want to die, but in the next moment, they don't feel that way anymore. And so since we know that, we've got to help people get through that moment, right? So that brings us to beneficence, right? This principle where we want to do good for patients. So the ethical, kind of difficulty here is that your patient might not feel like you're helping them when they want to die. But, like I just said, knowing that this might be brief for them and that we can expect it to not last forever for them is really important. So Mark, we had talked about, putting in some slides about myths, right? And we didn't really have time for all that, but, you mentioned that myth of, I think sometimes people think that if we take away one method of suicide, somebody would just use another method because they're always going to feel that way. Once somebody makes up their mind, they're sure about it. But that's not the case, right? We know that if we can get somebody through that moment where they're at that low, oftentimes people feel better later on. So then our third ethical principle at play here is non-maleficence, right? So not doing harm. So potentially, we could do harm by ignoring or not taking seriously enough people's potential for self-harm. So we have to ensure that the patient does not harm themselves, and that's through proper assessment, treatment, follow-up, which we'll talk more about as well. So what about confidentiality? Generally, we keep stuff confidential with our patients, right? But in this case, safety kind of takes precedence here. So for me, working with children, that always looks like a conversation at the outset where I explain that any kind of risk, I'm going to have to make an effort to keep them safe. With children, that almost always looks like talking to parents or guardians and working with the people who are around that patient to keep them safe. And so we have to make efforts to basically get anyone involved who is needed to keep that patient safe, even if that breaks our typical kind of confidentiality. So legally, I want you guys to look at this part of the Kentucky Revised Statutes about causing a suicide or assisting in a suicide. So it says a person commits a Class D felony when the person, with the purpose of assisting another person to commit or to attempt to commit suicide, knowingly and intentionally either provides the physical means by which another person commits or attempts to commit suicide, or participates in a physical act by which another person commits or attempts to commit suicide. Your ears hopefully are buzzing with those words: commit, attempt to commit. We don't want to say that anymore, right? Not a good, it doesn't convey the tragedy of suicide, and it certainly isn't a crime. So again, thinking back to that theory of why people die by suicide, right? The sense of belonging, right? That we need to keep living, basically. If we say that somebody is committing a crime by dying by suicide, what does that convey to people who are having those thoughts, right? Immediately, it like heaps on the shame and the guilt, right? Which contributes to not feeling like they belong. So we don't want to say commit suicide, but in the law, that's how it's written. So basically, it's pretty clear there, right? We cannot assist in any way. And I think that our duty as mental and physical healthcare providers is higher than, anybody on the street, because we should have training in this, right? We should know how to help people and not do harm. So certainly we can't assist in a suicide, but also I think we need to do better. So what about in a peer relationship? So who is a peer here? It's our friends, coworkers, colleagues. In healthcare, it's anybody with no previous patient-nurse relationship or patient-doctor relationship, or it's somebody who's, maybe you've treated before, but now they're just your friend, right? So there are certainly fewer legal implications for the reasons I was just explaining, right? That we kind of have this higher calling to keep people safe when we're doing our jobs. But similar ethical considerations, right, about confidentiality and especially autonomy, right? When it's your friend, I think you have more of this idea that like, I, should keep my hands off of this or let them do what they want to do, right? But again, if we know that suicidal ideation and suicidality is typically brief, don't we have an ethical obligation to help our friend get through that, even if it's tough in the moment, even if we have to help them in ways they don't want to be helped right now. So let's talk a little bit about chronic and toxic stress. Let's see, did that take off my presenter view here? Sorry about that. There we go. It's back. I was trying to check the time, but I can't see the time with the slides up. Here we go. Now I can check the time.
Doing well.
All right.
You got time.
Okay. So chronic and toxic stress. Let's talk about that, because I think in healthcare, certainly you guys can understand why we're bringing this in. So first off, when we think about stress, we need to recognize that not all stress is harmful, right? So let's talk about different types. There, positive stress, you can think of as mild, temporary, and when somebody has significant support. Notice we put there that it often improves performance. So if I was talking to a group here in front of me, I would say, give me some examples, but I will give you the examples. So think about, a little bit of stress before you take a big test, right? A little bit of stress is going to make me want to study harder, maybe plan better, think about how I'm going to space out those study sessions over time. Or if you're anything like me, cram at the last minute and get ready for that test the next day, right? If I didn't have any stress about that situation and I just showed up and took the test, it wouldn't go as well, right? So that's positive stress. Tolerable stress, kind of in between, right? It's moderate, it is temporary, buffered by supportive relationships, and it's significant, but manageable. So think about like the loss of a loved one. Pretty stressful, right? Especially depending on your relationship to that person, significant stress. But typically you have people rally around, you have enough support, you get through it with the help of other people. That's kind of our tolerable stress. Or maybe you are a CPA and you are in tax season, or, you know, it's something that goes away, and you can manage it. But when we think about toxic stress or chronic stress, that is intense, prolonged, and with limited or no support. So think about, you know, a child who's stuck in an abusive environment, can't get out of that, and certainly prolonged, and with little support, right? You know, this is something that comes up in my work a lot. Clearly, there's a line where we have to report abuse or neglect. Oftentimes kids, and I'm, you know, oftentimes adults too, I'm sure you see, Mark, are in kind of chronically stressful situations, and they come to therapy, and we can offer, you know, tools to manage the stress, but really sometimes we know that the antidote would be for that stressful situation to go away. For me, that's sometimes talking with kids and teenagers about how to, you know, get out of an argument that's happening in the living room and go into their room, or, you know, things like that. But in healthcare, there's plenty of ways that we could get into kind of chronic stress situations, right? So specifically for healthcare workers, we're thinking about stressful work settings that I think we all recognize as particularly stressful, right? Like emergency departments. Shift work is a risk factor for suicide. And working long hours. Think about, you know, when you're asleep and everyone else is awake, and then you do that every single day, working night shift, that can get depressing. And again, with this idea of like chronic stress, that really contributes to hopelessness, right? Which is a risk factor for suicide. So exposure to aggressive and violent patients, vicarious trauma. So working with people who've been through a lot of stress or even trauma. Vicarious trauma is when you kind of internalize someone else's reaction to trauma, and when you feel deeply for that person, and it can kind of affect you in a similar way. So then we have heavy workloads too. I heard on the radio this morning as I was driving to work, they said that today, 3 years ago today, I believe, was when President Trump declared a healthcare state of emergency for the United States. So the pandemic, right, has really changed what healthcare looks like, and certainly during all that time in hospitals, what a heavy workload that contributed to a lot of stress. So, you know, being asked to do overtime, and in healthcare, it's caring for people who are sick and need help, right? So turning down overtime can feel stressful also. So then for nurses specifically, think about like team conflict, lack of autonomy, right? In kind of our hierarchical system, kind of a lack of control over situations, right? Work-family conflicts, and just kind of the stress of lower status or perceived lower status in clinics or hospital settings. Here is also the risk factors that ANA has listed, similar to the previous slide, but I think it just kind of adds a few things as well. So exposure to repeated trauma, scheduling long consecutive shifts, repeated requests for overtime, workplace violence, incivility and bullying, inadequate self-care. And of course, self-care is really difficult, right? When you have all of these demands on your time. I remember well, I'm assuming all of you guys have heard that term self-care before, right? It's been kind of a buzzword, I think, in the past few years. But it's really just going out of your way to like take care of yourself, right? And oftentimes people think of like going to take a bubble bath, or, you know, having a nice dinner, or going for a run, right? Self-care. I can remember in a time when I think I had just had my son, he's 4.5 now. So I was in graduate school, and pretty soon postpartum, I was kind of getting back into classes. Somebody did a workshop about self-care, somebody in our graduate program. And I went to that meeting, and she started off and said, you know, tell me in the last week, when is the time when you participated in some self-care, and tell us about that. And I had, you know, probably a 2 or 3 month old baby at home. And I don't, you know, for those of you with kids, you probably understand that in those first few months with little ones, there's not a lot of time for yourself. So at the time, I remember just thinking like, self-care, you know, that's ridiculous. There's no time for self-care. So when you're in a state of stress that doesn't seem like it's ending, doesn't feel like there's time for self-care. And, you know, obviously like the postpartum period, that would, if we're thinking about our levels of stress there, that would probably be in our tolerable stress category, right? Time limited. You know that it ends, but when it's if your job is causing you chronic stress, that doesn't feel like it ends, or that you have control over that sometimes. So also fearing for one's safety or the safety of loved ones. I think that this might come from seeing things happen to other people, right? Caring for other people's injuries or healthcare needs obviously enters those thoughts into your mind. Isolation from family and friends, again, with like shift work, that can really increase isolation. Financial stressors, access to and knowledge of lethal substances. So again, that risk factor directly relates to our kind of 3-part conceptualization of why people die by suicide, right? That contributes to that acquired ability to enact lethal self-injury. We have constant high workplace stress, loneliness after relocation or transfer or a new job, issues with management. So when people don't feel supported, right? When they don't feel that sense of belongingness, work-life role conflict, or feeling unsupported in the role, feeling like you don't belong. So there, it's almost the exact words, right? Or feeling unprepared for the role, fear of harming a patient. I think that is also directly tied to kind of it's all rolled into the request for overtime and short staffing and things like that, right? When you're taking care of more patients than you feel like you should be, that increases your fear of harming someone, and that fear of kind of lack of control. Being evaluated for substance use disorder, kind of, you know, that pressure to be doing your job well, and then depression. All right, so after we, you know, talking about chronic stress, I think that leads us directly into types of trauma, which I know you guys had some questions about. So Mark, did you want to talk a little bit about these different types of trauma?
Sure. And as I'm talking through them, you can just advance the slides. We don't need to switch back to control and everything. So yeah, there's a lot of trauma exposure in healthcare, but also there's just exposure to trauma as a matter of life. And let's look at the different types of trauma and then think about how they relate to healthcare professions, but also just being a person. So type 1 trauma is acute trauma. This is where the trauma results from an exposure to a single overwhelming event. So an example would be like an assault or the death of a loved one, disasters or accidents. And characteristics of a type 1 trauma are the detailed memories of what happened, maybe a sense of an omen of like, oh, something else is going to happen soon, hypervigilance about maybe there's something else is going to be threatening in the environment. You'll see an exaggerated startle response where people jump a lot more than other people at sudden sounds or sudden images. There's a misperception of sensory information, and then maybe an overreaction to things that are going on. Well, that's type 1. So let's look at complex trauma, also known as type 2 trauma. There we go. So this is repetitive, prolonged, and cumulative traumatic stressors. So usually these are premeditated. Go back to 36, please. Yeah, premeditated, planned, or caused by other people. So in other words, they're interpersonal in nature. This is usually, type 2 trauma is not usually like car accidents and tornadoes, but it's usually something that's done by another person. It can include neglect. It often occurs at vulnerable stages of development, but can also happen later in life and in situations where people are vulnerable or dependent on others. Like if someone develops a disability, or if someone, say, has some cognitive decline and they're more reliant on other people. People who are exposed to complex trauma might be in denial of what happened, or try to minimize it in some way because it's a way to kind of manage the stress of it. There can be psychological numbing or dissociation, where part of how they manage the stress is by kind of disconnecting from reality, or rage. There's a lot of anger and rage that are predominant. It's a way to try to feel safer or to feel stronger. You see social withdrawal, and then a sense that I'm not going to be around much longer. Life is short, and you can certainly see how that could tie into suicidality. Crossover trauma, also known as type 3, this results from a single traumatic event that's devastating enough to have long-lasting effects. So examples could be like mass shootings or major accidents with multiple fatalities, dislocation of refugees, and then more recently, two big ones would be 9/11 and then the COVID pandemic. These can start perpetual mourning or depression. They're associated with chronic pain and impaired concentration, poor sleep, and irritability. And so let's go into the next one and then kind of tie these all together. Because vicarious trauma it's really a way in which our own experiences are changed by engaging with someone else's trauma. There's this kind of residue of emotion that comes from exposure to hearing about other people's trauma stories and being a witness to their pain and fear that results from their trauma. In other words, it's sort of like the trauma of being exposed to other people's trauma. And so thinking about healthcare settings, especially say in the emergency department, in some cases you have all of these combined. You are with type 1 trauma, it's acute, and sometimes it's happening to you, but other times it can be you seeing it happen to another person, or hearing details of it happening to another person. It seems like these things keep happening over and over again. So you might think of there's almost like a complex vicarious trauma in the fact that you're repeatedly exposed to other people's traumatic experiences. And then certainly in the last few years with the pandemic, crossover trauma has been a huge factor in the healthcare industry. So in terms of outcomes of exposure to trauma or chronic stress, there are quite a few here. I think most of these have popped up on earlier slides. But functional impairment, poor social relations. If people are more angry or they're more withdrawn, it's going to be harder to get along with other people, They're more likely to be isolated and depressed, anxious and irritable, and more aggression can come out, whether that's verbal or physical aggression. Because trauma and chronic stress are associated with increased levels of inflammation, you're going to see people are at a higher risk for having heart disease. Also, the way your blood pressure goes up when you're under stress can be associated with that. You see, basically, think about all these symptoms of trauma and chronic stress, and think about risk factors for suicide and suicidality. Changes in appetite, substance use, avoidance, problems with sleep, concentration, relationships. I mean, most of these are identified as risk factors for suicide and suicidality. But another one I wanted to note is that hyperactive inflammatory response. There's some research that shows that's also associated with discrimination. And so in certain minority groups, you see more inflammation and a more hyperactive inflammatory response to new stressors or new illnesses. Dr. Chase Wise, I'm going to turn this one back over to you then, just to kind of pull it together.
Yeah. So let's talk a little bit about peer suicide prevention. So step one, we want to notice warning signs in our peers, right? These are things that we've already talked about, but I want you to think about these risk factors again, or kind of these signs of risk, and think about how that might apply to peers at work or peers in your everyday life. So those signs of immediate risk, like talking about wanting to die or kill themselves or looking for a way to kill themselves, those are our more immediate risk signs. But then there's those other factors, talking about feeling trapped or talking about being a burden to others, and those other factors that we've discussed. Something I wanted to point out here is that those signs of immediate risk, how often do you really hear people talking about that out of the blue? People don't just, sit down and chat about those things, right? Which I think is a really good reason for us to hone our assessment skills, not only with patients that we're working but with our friends and family members. We have to get more comfortable asking important questions because people don't usually just sit down and talk to us about that stuff. So our next step is to ask people, ask about suicide. So for example, you could say something like, hey, you seemed really overwhelmed lately. Sometimes when people have been feeling down or anxious for a while, they have thoughts about suicide. Have any thoughts like that come up for you? So notice how it takes the pressure off, right? It says, this is a common thing that lots of people struggle with. Has that come up for you? Notice that what I don't say is, hey, you're not thinking about suicide, are you? It's like sometimes we are so afraid of the thought of that we frame it in a way that is just asking somebody to say no, even if it's really a yes, right? So we don't want to prime people to say no if it's really yes. Because the implication when I say something like, you're not thinking about suicide, are you? The implication is, because that would be crazy, right? That would be awful. And maybe I can't handle hearing that, right? We want to convey that we can handle hearing a yes response if that has happened. Which brings us to our next step, to express empathy or compassion in some way. So we're not panicking, right? If somebody says yes, or they have had thoughts like that. When people feel really overwhelmed, like Dr. Shermer was saying earlier, we are looking for a way out, right? And of course, what we want are healthy coping skills, but sometimes suicide is on the menu and it looks attractive to people. And so we can at least express empathy with their feelings of overwhelm, right? So then we need to help our friends or peers access appropriate resources or services. And, sometimes that looks like a referral to a mental health provider, or helping them come up with kind of a plan for coping, which we'll talk a little bit more about as well. I think also it's important to think about kind of system-wide prevention. If we think about that sense of belonging, there's things that we can do just within our organizations to shift that culture more towards emphasizing well-being and talking about this kind of stuff and talking to each other. And so I put on there socialization of new employees. We want to, uplift each other and make it a safe place to talk and not treat people like they're being hazed, that sort of thing. I don't think that's prevalent in most organizations, but certainly like in high stress jobs, there can be this sort of just do your job, get stuff done kind of mentality. So kind of changing that a little bit. We also want to utilize those coping skills for ourselves, right? And stick to a plan of self-care. I was talking about self-care earlier in a time in my life when it didn't feel easy. Self-care can look not like a bubble bath. That could be getting enough sleep at night or during the day if you're working night shift, right? But prioritizing those things. So I'm being mindful of the time here so that we leave some time for questions, but let's quickly talk about assessing for suicidality. And Dr. Shermer, did you want to go over these slides or did you want me to go over these slides?
I'm happy to. I mean, these are general types of questions that you can ask, at intake. I was coming at this from a clinical perspective, but some of these you could ask maybe in a more conversational way with other people you're worried about. But ask people, like, if you're assessing a patient, can you give me a history of any suicide attempts? So you want to find out, like, what means did they use? Listen for lethality. Listen for if they were using that in some sort of operant way or whether it was a respondent way. Find out, what's kept you alive. All right, so you made this attempt a number of years ago and you haven't made any attempts since then. What's keeping you alive? What's keeping you from doing this again? And really finding out what was going on in your life at the time. So if the situation that motivated that attempt is still a concern, then that should be really part of what you focus on in treatment. But really, it's important to focus on open-ended questioning rather than data gathering. You don't want to just ask people a bunch of yes/no questions. You want to give them space to talk about themselves. One, because they're going to share information that you might not think to ask about, but also that increases their sense of connection to you. And so having more of a sense of connection to you as a provider or to one another, or just as colleagues, is going to be a lot more important than just checking a bunch of boxes. People can tell when you're just checking boxes, and it can feel very impersonal. We don't want that. There's a screener called the Ask Suicide Screening Questions, and it's a series of 5 questions. The research shows that you can use this on patients ages 8 and up. And as we mentioned before, that children aged 8 and up are at a very high risk for suicide as a cause of death. So these are the questions. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt you or your family would be better off if you were dead? Think about how these questions also reflect some of the risk factors that we identified earlier. In the past week, have you been having thoughts about killing yourself? So it's not just, having a thought, but or do you wish you were dead? Do you think that you'd be better off or that other people would? Have you ever tried to kill yourself? We don't need to shy away from the words. I mean, that's one of the things that happens a lot with people who are struggling emotionally, is they avoid things. And if we as providers also avoid, we kind of reinforce that these things are shameful or that they can't be talked about. So have you ever tried to kill yourself? If so, how and when? And so if the person says yes to any of those first 4 questions, then you want to ask, are you having thoughts of killing yourself right now? If you're considering hospitalization for someone, you want to ask things like, well, what makes suicide an attractive alternative at this time? and listen for themes of helplessness and hopelessness. What plans are in place? Do they have detailed planning? Have they specifically said, I'm going to follow this step and this step and this step, or they're just like, I don't know, I think I'm going to do it. Do they have highly accessible means? Do they have access to highly lethal means? I mean, this is back to what we were talking about earlier about the knowledge of what is lethal and access to it. How do you feel when you think about death? So you want to listen for themes like peace, calm, escape, and relief. If whenever they think about death or whenever they think about suicide, it's very frightening to them or disturbing or disgusting or upsetting, then you probably want to have this person assessed for something like OCD. And then you want to ask, what's keeping you alive? Respect anything that's keeping your patients alive. If it's their pet rock and they love seeing their pet rock every morning when they wake up, then man, that pet rock is super important. We don't want to minimize anything that is meaningful to the patient. And then listen for any sort of contingent and reversible barriers to death. You know, as long as I don't get fired, or as long as my wife survives this illness, you know, that could be something that could suggest a higher risk if something is very reversible. Don't give friends and family members the task of watching their at-risk loved ones. Making that their job only sets them up to experience a whole other level of trauma if this person were to ultimately die by suicide. And one other thing, I've heard anecdotal instances of providers trying to be very well-meaning and taking possession of a patient's firearms to help prevent them from getting hurt. That's a huge, huge liability issue. So please, please, please do not take possession of or transport or safely keep firearms for any of your patients. With regard to suicide assessment tools, there are some problems there. Many of the measures that are available aren't validated on diverse populations. So they're mostly, you know, straight middle-class white people. And it can be difficult to establish reliability and validity of the scale. So the way to do that is you'd have to give it to a bunch of people and then follow everyone longitudinally and see who attempts suicide, who dies by suicide, who never makes an attempt. You know, the amount of research that would go into that is daunting and almost undoable. And so to try and establish how reliable and valid these are, it's very, very difficult. Using any kind of tool to assess suicidality has limited, it really has limited benefits. It can support clinical judgment, but it's not like you can make every decision based upon what someone says to some assessment tool. Really, interviews are the most effective method for assessing suicidality. So you really want to assess the person, what's going on in their life and their mind, and not just the behaviors. Again, we're not just checking boxes.
So let's talk a little bit about safety planning. So step one, we want to look at ask about the warning signs and ask, what do you experience when you start to think about suicide or feel really distressed? And from there, help them figure out what their coping strategies are. So what they can do on their own, if they become suicidal again. And that can look like all sorts of things, like Dr. Shermer was talking about the pet rock being an important reason for living. We can't, overlook any possible coping strategies. We also want to help them identify social contacts or social settings that help them take their mind off of problems for a little bit. And I always talk with, I'll go on to the next page here just to talk about the family and friends who might help as well. So who do you think among your family and friends you could contact for help during a crisis? That kind of sometimes gets rolled in with, preferred social contacts, but I always make sure to let, especially teenagers who are having trouble talking about this stuff with, maybe their parents or somebody. It doesn't always have to be that you're contacting someone and saying, hey, I'm having thoughts of suicide. Can you help me? It can just be, hey, what's up? What are you doing? To reduce isolation in that moment. And so then we want to offer, help them identify professionals that could be part of the safety plan, including the National Suicide Prevention Lifeline. That's 1-800-273-TALK. And there's also this new text number that's really cool, texting 988. And then step 6 is list the strategies to make their personal environment safe or limit access to lethal means. So like removing firearms from the home and destroying unused medication. So then with treatment planning, you know, you make the crisis plan and explain the limits of confidentiality during the informed consent process. Then make that safety plan, like we had just kind of reviewed. So then we want to, you know, talk about identifying the problem. You know, safety is kind of problem number 1, but then what are the drivers of that suicidality? And this is what the patient identifies these, not us trying to make assumptions about the sources of that pain. And then, you know, that leads us to appropriate therapeutic interventions, where you identify and treat appropriate coping strategies, or I'm sorry, identify and teach appropriate coping strategies and alternative behaviors, build their problem solving and mindfulness and acceptance skills. And note that our goal is not pain elimination. It's teaching how to tolerate that pain so that we can still function and get through and thrive in our lives, right? We cannot take away people's pain. So identifying the locus of pain, you know, where it's coming from, and increasing distress tolerance and coping skills, improving cognitive flexibility and, you know, resilience to face something similar again. And, you know, all this strengthening of flexibility and problem solving helps to build resilience and help people to approach things differently in the future. And then identify the goal of the behavior, as Dr. Shermer's mentioned before. You know, is it respondent, operant, or both? And then help patients find non-suicidal ways to obtain those same desired outcomes. Let's see. So our prevention strategies are to identify people at risk, strengthen economic supports, strengthen access and delivery of suicide care. There's a huge provider shortage right now. I know that in mental health care, there are such long wait times right now just to get in with somebody, which clearly is difficult with suicidality and treatment of that. We want to reduce access to lethal means, promote connectedness through community engagement, things like that, help our patients get connected to mental health providers. And so then lessening harm and preventing future risk includes postvention. So implementing program after a suicide for survivors of suicide, and then safe reporting. So that's reporting that includes suicide prevention messages, stories of resilience, risk, and protective factors, and links to helpful resources, avoiding sensationalizing events. For example, it's a recommendation that reporting doesn't include even like the method of death, because that can kind of sensationalize suicide.
So this would be a good stopping point for us to take some questions. And
Sure.
Doctors, very well done. Appreciate your work on this and your comments. Getting lots of questions here. Let me, Mark, you mentioned specifically, but Amelia as well, the role of family in terms of prevention, but also some of the most uncomfortable conversations I've had to have is with families after a completed suicide. Any thoughts about not forgetting those families after completed suicide, or how, you know, because the whole issue of copycat attempts or suicide comes up?
Well, I mean, that's what the postvention idea is, that there's prevention and then there's postvention. And so those are interventions that are done after someone has died by suicide. So getting the family connected to services, therapeutic services, teaching them coping skills, like getting them connected to support groups for survivors of people who have died by suicide. I mean, that's all important. Part of that follow-up, once if someone a patient has died by suicide, we need to be doing some sort of follow-up with their family members to help them reduce the risk of additional suicidal behavior within the family. I mean, it's tragic enough to lose one person, but there are cases where it's multiple people, and it's just unbelievable.
Another question came up about any studies that maybe show the relationship of suicide with violent games on TV or violence on TV, violent video games.
I haven't delved into that. I think the connections there are not sure how strong they are. I don't want to just make up data, but I haven't read research on that.
Yeah, I also can't give like specific data, except just that it's not as strong as I think people assume. Research is pretty, and that's an association people have tried to research and look for, but it doesn't appear to increase violence, even violent video games.
More questions are coming in about how then do you supervise a patient when they are at high risk. A couple comments of patients that repeatedly come into the ER voicing suicidal ideation. They're assessed and sent home, but if we're not to ask family to supervise it, what is the best choice if it's determined they're not an immediate threat to themselves, don't meet inpatient criteria, but what happens then?
Well, it's not that the family's disconnected. It's just that it's not their responsibility to make sure. I mean, part of it is helping them foster that connection. But as I was saying before, there are cases where I've had these patients who have been sent to me where they've not been identified as having something like OCD. They're in the emergency department frequently talking about having thoughts of suicide. Again, is their emotional reaction to these thoughts being assessed? So in some cases, you'll see this if people are having suicidal obsessions, they are in the emergency department a lot and they do get sent home because they'll say, I'm having these thoughts, and I wouldn't, part of why they're getting sent home is because they're saying, I wouldn't want to do this. And yet the next week they're coming back. They're not being evaluated for another mental health diagnosis that might cause them to obsess about the possibility of suicide. So that could be part of why they're coming back in a lot, is because they're not actually actively, intensely suicidal. They're obsessing about it. Another thing is looking at what's motivating that. Okay, if they're coming in, what are they looking for? And is there another way to get that need met? Are they coming in because they want somewhere warm to be? They want someone to talk to? Are they coming in because they really truly are experiencing suicidal intensity? What resources are we getting them connected with? What other services, as opposed to, well, you're not going to do it today, so we'll send you out. There's people who keep coming back. It might be a variety of different reasons. It could be that they need to be assessed at a higher level as well. Maybe they need a more intensive assessment. I don't know what your thoughts are, Dr. Chase-Wise.
I'm thinking along the same lines of what's the goal? What's the function of that? Coming back over and over to the ER. In the case of kids and teens, sometimes I see that where maybe the emergency department or, an intensive kind of crisis center is the only place where they get those thoughts taken seriously. And so I think like we can model to families that we take these thoughts really seriously, and, making safety plans and that sort of thing, and really modeling to, parents and caregivers how these are really intense thoughts and really important to take seriously. I think sometimes especially kids and teenagers, if they were getting that at home, from their loved ones, if they were getting that, their thoughts taken seriously, maybe it wouldn't get to the point of getting to the emergency department.
Another question from an attendee early on was, she was told by a police officer that if there's no note, they have to document it as an accidental overdose. Any thoughts about that?
Well, I mean, that gets back to how the numbers we have on suicide don't necessarily capture what's happened. And there are some cases, family members will find the note and destroy it because they don't want other people to know that someone in their family has died by suicide because they perceive social stigma attached to it. So just, I mean, that's one of the things about it is the numbers that we have on suicide are clearly underestimating how much it actually happens, even though we've identified it as one of the leading causes of death.
Lots of questions coming in about the lack of access and resources. So we know this is an ongoing problem. I wonder if either one of you are aware of information or statistics specific for Jefferson County or Kentucky. I know you're looking at kind of national numbers in your presentation, Mark, but are we aware of any direct efforts, community outreach or suicide prevention programs going on in Jefferson County or Southern Indiana?
I'm not sure specifically by name. I mean, I know a lot of organizations have this as part of what their mission would be. I mean, in a lot of them, it's built into it. So obviously, in our organization, we're doing what we can with our patients to prevent that from happening. In terms of specific, I don't know off the top of my head of like a specific program by name that has this as their mission statement.
One last question, asking specifically about the Columbia Suicide Severity Assessment and clinical trials. Or do you know of any active trials going on at the federal level on using these particular tools? How accurate or validated they are?
Yeah, I don't know right offhand about specific studies that are being conducted right now. Again, what I did highlight before was just sort of the methodological problems of validating these, which is not to say that we shouldn't use them. It's just difficult because you would basically need to administer it to a bunch of people and then follow them over whatever period of time and see who attempts and who completes suicide. So I'm not up delving into what studies are being done. I'm not aware of. I'm sure there are, but I just don't know if they are.
Well, we just got a couple minutes left and we need to ask our follow-up question. Dr. Chasewise, thank you so much. Dr. Shermer, excellent job.